just 2 days ago, as a consequence of that commission of the National Assembly of Quebec, which noted the outcry of patients organized around the Association Québécoise de la Maladie de Lyme, so the Quebec Association, as Christian mentioned. So just 2 days ago, a government institution called l'Institut National d'Excellence en Santé, I think it's the equivalent of the NICE, N-I-C-E in England, issued a series of documents and reports to open up the debate about the necessity to recognize the fact that there are important shortcomings in taking care of patients, related in great part to the shortcomings in the diagnosis. And as you see, I'll come back to it a bit later, in the title, Situation actuelle et accompagnement vers le changement. The actual situation and the accompanying, or comment on dit accompagnement? Support towards change. So you notice that it's already an editorial, I would say, statement here that a governmental institution, INES, which is overseeing the standards of care in Quebec, is ready for some change. Since I was asked to talk about Canada, I want to mention a few words. Even in the western part of Canada, British Columbia, where there is historically, as in western United States, little incidence of Lyme, the Lyme incidence relatively is peaking within the limitations of the surveillance, which is hugely deficient everywhere in Canada, much more than in the United States, but specifically in the West. But you see the same trend everywhere. This is Ontario, with estimated risk areas everywhere in the most densely populated regions of Ontario. You see there Mississauga in the center of, where's the pointer? Oh, sorry, okay. So here is the Greater Toronto area, which almost more than 50% of the Ontario population, and it's now recognized as a high incidence zone of that province. Now, these figures are and recognized even by official authorities everywhere in Canada, are highly underestimating the situation. As you see, there is here a comparison between, I think it's the paper with, that VET published, I think 2 years ago, or no, last year, that was just last November, comparing the incidence in different Canadian provinces between 2014-2016, comparing it to the US incidence in limit-trough zones in the states that are near these provinces of in Canada, and you see a tremendous difference, 100-fold time, for example, in Quebec. In 2014, it tends to be corrected a little bit, but as Christian mentioned, some of our colleagues believe that, you know, at the border between US and Canada, there are border people stopping ticks. So this is the situation actually. And now to also indicate, I think, Vet, you were involved in this study too? The incident, no, you weren't involved in this one. Because, of course, Vet is involved in almost every study about Lyme in Canada. There was a study carried throughout all Canada doing testing on mammals and, on ticks and their positivity for Babesia. I say Babesia, for Borrelia. And during the 4-year period studied, up until 2016, there were more than 1,200 ticks that were, with 27 species that were tested. 15 of 18 species that were tested, because not all of them were tested. 15 out of those tested were positive for Borrelia, and 6 of these species are biting humans. So I'm not a specialist in the biology of humans that are bitten by ticks, but I always wondered why there is such a limitation in our understanding about the possibility of other ticks transmitting actually Lyme to humans. Anyhow, we have there at least an important indication that although these ticks might not transmit it directly to humans, but there are many ticks around in Canada participating in the enzoonotic cycle of Borrelia among mammals, among birds, that then can, through the Ixodes scapularis, the black-leg ticks, transmitted at least in the eastern parts of Canada. Now, as mentioned, I came to Lyme just by, I must say, by the politics, because as an infectious disease doctor working in the greater Montreal area, Lyme was never on our minds as doctors. As I was trained as a microbiologist in infectious disease, it was a more US disease, and even the controversy around it during the 19th and years 2000 didn't really touch us or concern us that much. Although, well, from time to time we would have somebody bringing us a tick or signaling a tick bite or even an erythema migrans, but it was very, very limited as an experience of a doctor, and we weren't exposed really to cases. Actually, we didn't know we were exposed to cases, although as a microbiologist in my field, often we have had in the past, now that I think of it retrospectively, many patients referred to us by other physicians looking for the situation of patients with chronic fatigue syndrome and asking us to exclude infections. And we carried a series of tests. In my case, before politics, I never tested Lyme. I sometimes tested Bartonellosis, and we found some important, some relative importance of Bartonella positive serology among our patients in my hospital, but we usually believed, because there were no incidents of cat scratch associated, we usually believed it was positive serology, as was mentioned by somebody from the health authorities, until we observed so many of them, and sometimes in a familial cohort of people linked together. Actually, 4 years ago, a colleague of mine of my hospital identified 4 children, their 2 parents and a grandmother, all positive with high-level Bartonella serology. It was brought to the attention of Ed Brachworth from North Carolina, and a study was just published in March this year, indicating that in all those 7 patients, there was a persistent Bartonella bacteremia. So I'm talking about this just to say that we, doctors in Quebec, even infectious disease people like me, open to these issues, were usually considering as non-pertinent the possibility of these tick-borne diseases in the type of situation. But the patient association, probably realizing that I'm the health spokesperson and one of the 3 members of parliament from a party which was open to any initiative coming through public mobilization. I'm from a left-leaning party in Quebec, which is based on public and community organization. So they sensed that, they organized, and they came to see me about 3 years ago to see what they can do. So we thought about it, and we thought that the best way was to petition. So they gathered a petition of 15,000 signatures. It went through the usual process of petitioning, and with the help of another colleague from another party, we convinced the authorities of the Health Commission of the National Assembly to have a special commission on that issue, and that's where Christian Perron and Vett Lloyd and others, I think Dr. Hawkins also, were invited as external experts. And at the end of that process, the government gave the mandate to, and that was the mandate. No, I'm sorry. I was willing to talk about the federal. I'll come back to that. Before we did that in Quebec, there was an initiative in Canada 6 years ago by a member of parliament from the Green Party, the only member of parliament by the Green Party, Elizabeth May, who brought a bill in the Canadian Parliament a little bit along the same path, by public mobilization, by associations in her riding. And there was a bill that was passed and became a law asking the government to provide support and convene a conference with provincial and territorial ministers and to develop a federal framework about Lyme. But the important thing is that also in the Canadian Parliament it was indicated that this initiative must include patient groups, okay? Now, in 2014 it became law, and 4 years later the federal government announced $4 million as its first and significant major investment in research and support for Lyme, taking care of Lyme clinically. But actually in Canada, at the federal level, there are two networks of Lyme research. One is dominated by, I would say, where is it? I have forgot to include that second one. There are two consortiums, and the second one, which name is missing here, is mainly dominated by doctors, by officials at the different levels of government. And the first one is the Canadian Lyme Consortium that I think you were involved in that, Vett, and which is, is a three-way partnership between community activists, healthcare providers, and also scientists like Vett Lloyd. But unfortunately, as you might guess, the $4 million went to the other Lyme Research Network, which probably has already its idea about the problems related to Lyme. So I was talking about the initiative in Quebec. It came throughout a petition, as I mentioned, and it took about a year and almost a year, because it was due to be produced in the beginning of May. Finally, it was 2 days ago that the Institute of Excellence in Health published this report with numerous documents accompanying it for doctors, for other healthcare practitioners, for people who take care of adults, for child, and diagnostic tools. So it's a very comprehensive report, which is meant for there are two sections. The first section is for the stade précoce, the early Lyme that we are in the report is identified as a localized or early dissemination of the disease, and a second report which will then take into charge the whole debated and controversial issue of chronic Lyme, will come about a year from now, we hope in the month of January. Fortunately, the INES has accepted that among the 3 doctors who are reviewers, I be included, and also another doctor who is another microbiologist heavily involved in taking care of patients in very highly endemic region of Quebec, in southeastern Quebec. And both of us are keenly, on est conscient, comment on dit? We're conscious of the obstacles that we must overcome because IDSA is the IDSA approach, and the IDSA, I must say, is acting as an enforcement body, not only in the United States, but by all means in Canada, because as a small country next to the United States, almost all our guidelines, all our approach to different diseases, including infectious diseases, are vastly, sometimes solely based on US guidelines. So IDSA has a large impact in what the health community and the health authorities believe and carry as message to the population. But as I mentioned, due to that mobilization of patients through the initiative of the petitioning the National Assembly, finally, I think we can count on the fact that this statement here, that there is a recognition that there must be change, is easily retraceable in the executive summary of the first report, which really begins by saying, listen, first, the register of those reported cases doesn't reflect the disease in its all extent in Quebec, and the available data do not really permit an appropriate evaluation of the extent of the disease. First recognition. Then the second recognition is that there is a general under-knowledge about Lyme disease even among physicians, professionals, health professionals, so we have to correct that. Now, it says also that there exists really little scientific literature about the efficacy of the single-dose post-exposure prophylaxis. So there is a warning even about that, because the actual guideline of the health authorities in Quebec is a single-dose prophylaxis of double-dose doxycycline. And it states that the Lyme disease can have really important repercussions on the quality of life of patients. So everything in that opening statement is recognizing that the disease is much more important, much more wider implications for the population that was previously recognized, and also stresses that the offer of service of laboratories in terms of diagnosis must be improved, that it's not satisfying at the actual situation, and so on and so forth. So I think there is a considerable gain in sight. Now, just to finish, because it was of interest for Dr. Zhang, who asked me, what am I doing exactly now as a physician? And it's interesting that he asked me this question, because I'm basing, I think I told you. In fact, I'm treating patients. I'm treating patients not in private, but in public, and it's open. In my hospital, which is in the public sector. I have the support of the direction of my hospital, which is in fact the chief executive officer of one of the 14 big health organizations on the territory. The lucky situation of ours is that his nephew has had chronic Lyme disease for some time, and has made him much more open to my suggestion to support my initiative. So he allowed a budget so that we can have a clinic to treat patients, any patients with vector-borne diseases, not only Lyme. So for the moment, the hospital has dispatched a nurse who is among us here, Madame Karine Apréau, who is in fact participating in her first conference about Lyme. So I think you should all grade her presence here. And the hospital will soon also hire an epidemiologist and a clerk so that we have a good team to take care of patients. I do treat patients. I do treat them for long periods of time, more than 6 months. And I do treat them with multiple antibiotics, and that's where Dr. Zhang comes in, because I used to treat them with single antibiotics for some time with some interesting results, but relapses, then getting to, because as I told you, I'm totally new in the field. I know very little about all that. So I base my approach to what has been done in the last 15 or 20 years by people in US or in France like Dr. Perron, but more specifically in the choices of the drugs by the work of Dr. Zhang and the type of work of him and his colleagues. And actually, since January, I have begun to test, or a bit later, I've begun to test everybody that comes in my clinic to test for their GCSPD in light of the fact that I might need Dapsone one of these days. That's about all. Thank you for your...
In England, there were 7 doctors that I'm aware of that were treating patients with long-term antibiotics. Every one of them was reported to the General Medical Council, and everyone had sanctions against them. One retired, he was close to retirement and decided not to fight. One did fight and lost his case, and may be treating, is no longer treating, to the best of anybody's knowledge. One said he wouldn't treat anymore and lost his license for 6 months. It was reinstated. Do you feel that there's any danger in Canada of similar tactics to being used on doctors that are using long-term treatment that is against IDSA and other guidelines?
That's maybe the virtue of doing politics before treating patients for Lyme. Actually, for some reason, let me say, first, I do that in a moment of time where there's much more scientific evidence for persistent forms, for the problems related to chronic Lyme. So it's a bit different for the cases of the others that happened in the past. Second, it happens that for other reasons, my passage in politics was relatively positive. I have still a place in the public debate. I intervene every week in the TV in a standard political analysis show. So all that offers a type of protection that makes the action of the governing bodies a bit more cautious about me. And third, I have initiated with the help of 2 other colleagues, actually the head of the Children Microbiology Lab of the University Hospital of Montreal, who published with Dr. Ed Bridgewater about the Bartonella cases. So she's very now sensitive to all these chronic crypto infections for which we don't have appropriate responses. And also another doctor from a university hospital who have had experience in US with Lyme patients. So we have submitted a project to the Quebec government to support the idea that not only for Lyme or chronic Lyme, but for all chronic diseases with a high burden on the quality of the life of patients who brings a lot of doctor consultation for many years, like for chronic fatigue syndrome or fibromyalgia, that the government should invest in a national, that means Quebec, center to take care, to provide care, and to do some research. So we're going to try to include my clinic as just as a pilot initiative in that regard. So in that sense, I think we are now heading in a situation where I don't think there will be any initiative to stop our action.
Thank you for that support for the people of Canada and the rest of the world. Thank you.
Thank you. Yeah, congratulations on setting that up. As Michael said, we don't have anything like that in England. But I think it's really important. I don't think there are many GPs here today, but I think it's really important to go back to basics and the fact that most cases are going to present as primary care illnesses and in primary care. And it's really key to get GP education sorted out. And that involves practice nurses, pharmacists, as well as GPs. And in the UK now, I'm leading a big educational project with the Royal College of GPs. And we've had charity funding to do that, but we've actually set up, we've just developed what's called a Lyme disease, the Royal College of GPs Lyme disease toolkit, which is online for anybody to look at if they wanted to follow up on our ideas. But the idea was that we will put everything on there, some basic information, how to get the testing done. This is aimed at doctors, but patients can read it. And already patients are finding if they go to their doctor with a piece of information from a patient support site, they sometimes get dismissed. But if they can go to their doctor and say, well, if you look on the official college site, it tells you what to do. And the doctors will, have nowhere else to go, so they will look at that and they will believe that. And we're really hopeful that we were going to continue to develop that with more research to add to it. But we've also developed, or has been developed already, a free e-learning module for doctors and nurses, so that we hope that they will pick it up early, diagnose early, give patient prevention advice, and maybe stop some of the chronic illness.
Fortunately, and I hope that will help also other jurisdictions, other countries, this INES report is institutional. It comes from the main body appointed by the Ministry of Health to standardize or draw guidelines for primary care practice. And these are in fact, the documents are all prepared with the intent to inform the practitioners, the public, but especially the general practitioners.
I just wanted to share some information in case you weren't aware of this and pose a question related. Interestingly enough, Canada is one of the few countries that has decided to use only one of 4 of the International Classification of Diseases codes for Lyme disease. So currently there are 4 codes. Canada is only using one, the one for the acute form of the disease, which means, of course, surveillance is very limited. It also, in the Canadian system, in many countries, the doctor or the medical practitioner will assign a code to the symptoms when the patient presents. And in Canada, the doctor does not assign a code. The doctor basically describes the illness as they see it, and then the code is assigned by a professional coder at the provincial level. Yeah, so there's very little communication between the medical practitioner and the professional coder, who's sitting in a provincial office that is controlled by bureaucrats who are very interested in, let's say, controlling the information around epidemiology and other medical conditions. So I was just wondering, given your experience with the political side, and because you have a lot of systemic obstacles in Canada, at the same time you have this progress, so just any of your views on what might happen here, particularly because the organization that's responsible for the codes, it's a private nonprofit, and so they have no transparency requirements for the public, the Canadian public, not at all. They do not have to report on anything, why they're doing it, how they're doing it. At the same time, their executive board is entirely held by government officials.
Actually, in that report, there is a section addressing the issue and recommending to change that coding system and to bring more specificity, to have subsections for properly identifying tick-borne diseases, Lyme, not only tick-borne, but Lyme, distinguish it from chronic and acute. So it's addressing, it will take time to.
Well, thank you, Amir. I just want to say that what you bring is so important for the Lyme disease community. You bring a ray of hope, a ray of sunlight, which just come out. Which I mean, it's been great the whole day, or the past 2 days. But this is so important. I'm really very encouraged because you stand up for Lyme patients. And this is really very important because I think for them to be convinced, we need to do more research, especially clinical trials, which you're doing. I'm really encouraged by that, by your openness to try these new drug combinations based on the research. But I think really it's important to set up the clinical trials properly and get the support to do that. Thank you.
Well, actually, you mentioned a very important shortcoming of the initiative as it is now. That clinic is really a first-line clinic in an atmosphere of, how do you say it, médecine de brousse presque. A war medicine, because we are at war, there is very little support. So the treatment protocols are not now adequately set to be published. So that's why we'll have an epidemiologist and some support to get it, in the right setting in order to be really, truly usable as a pilot project to demonstrate the, comment dit-on, démontrer le concept, to demonstrate the concept that it can work and it should work. And it gives hope to patients, especially to patients. That's what has moved me initially.